Good evening, dear colleagues. I am Jobairul, Joint Secretary of Bangladesh Medical Physics Society. I am pleased to welcome you
Yes, we
to
hear
the
you.
monthly webinar program.
Okay.
We all know the breast cancer is the most common cancer in women worldwide. October is the Breast Cancer Awareness Month, an annual campaign to increase awareness of the disease. Every year, BMPS celebrates Breast Cancer Awareness Month. Considering this, BMPS is conducting this month of webinar on breast cancer topics on the occasion of Breast Cancer Awareness Month. Today's webinar speaker is Mr. K.M. Masud Rana. He is the medical physicist from RSO of Department of Radiation Oncology, Evercare Hospital, Dhaka, Bangladesh. To encourage discussion and active participation, it is planned to have 10 minutes question and answer session after presentation. Now, I would like to request Mr. K.M. Masud Rana to deliver his valuable speech on radiation planning techniques he applies in view of upcoming challenges.
Thank you. Good evening, everybody. This is K.M. Masud Rana, medical physicist. So I'm working in the Department of Radiation Oncology, Evercare Hospital, Dhaka. So today we are going to conduct a webinar program, which is organized by Bangladesh Medical Physics Society. This is actually 5th monthly webinar program. So today, as this month is Breast Cancer Awareness Month, so that's why the topic was selected related to the breast cancer. So today I'm going to talk about radiation planning techniques in CA breast. So in view of some upcoming challenges or ongoing challenges or current challenges. So before going in detail, so I would like to share some latest information about Bangladesh cancer cases. So according to the WHO, so there was a statistics the source is Globocan 2018. So the total number of cases in 2018 is 150,781 cases, new cases in 2018. So out of this number, the male cases was 83,000, more than 83,000, and in the female, it was 67, more than 67,000. So in this 67,000, out of this 67,000, breast cancer cases was 12,000, more than 12,000, and which was 19% of 67,000. So which is really alarming and leading cancer cases among the females. So that's what it is a concern to our country. And if we see the global cancer incident, so we can easily understand that in Asia is in high risk for cancer, and in this Asia is occupying 48.4% cases, whereas in America it is 21%, Europe 23%, Africa almost 6%, and Oceania is 1.4%. But if we worldwide, if we figure out the common cancer, so we can understand by this incident record. So in the percentage of new cases,
Mr. K.M. Masud Rana,
yeah.
I think your microphone is a bit far away from your mouth. Please check it.
Oh, yes. So now it is okay.
Oh, okay. Thank you.
So this is the scenario for the cancer according to the 2018 database from WHO. So in that database, Lung is the mostly incident cancer cases, which is 11.6%, and breast is lung and breast is almost same. So, but in the mortality, lung is the number one, but there is a hope for the breast cases or breast cancer because it is number 5, and the mortality is 6.6%, which is compared to lung is less. So let us know about what is breast cancer actually. Breast cancer is a disease in which the cell of the breast grow out of control, and breast cancer can begin in different parts of the breast. So a breast is made up of 3 main parts, that is lobule. You can see from the photo that lobules, duct and connective tissue. So most breast cancer begins in the duct and lobules. So breast and lymph node to lymph vessels. When breast cancer spread to other parts of the body, it is said to have metastasis. So what is the kind of breast cancer? So there are two most common kind of breast cancer. So one is invasive ductal carcinoma, which grows outside the duct and into the other parts of the breast tissue. So this kind of cancer also can be a metastasis, and it can go up to the other parts of the body. And the second kind of is invasive lobular carcinoma, which is also spread from the lobules to the breast tissues. This is the common breast cancer treatment. So number 1 is the surgery. Depending on the size and stage of the tumor, I may have some breast tissue removed, that is called a lumpectomy, and all of it, when it is, then it known as a mastectomy. So common breast cancer treatment, one is surgery, second one is radiotherapy, very high energy X-ray, which is usually used for destroy or shrink the cancer cells, and radiation either delivered to the entire breast or tightly focused on where the tumor is or was. And the number 3 is chemotherapy. So what is the role of chemotherapy? Chemotherapy actually shrink a tumor before radiation therapy or surgery, which is called neoadjuvant chemotherapy. And some portion is destroy any remaining cancer cells after surgery or radiation therapy, which is called adjuvant chemotherapy. And some of destroy cancer cells that return or spread to other parts of your body. So these 3 are the common. Sometimes 2 modalities is combinedly required. Sometimes surgery is enough for the breast cancer. It depends on the staging, size of the tumor. So let us, I am just of our radiation planning. So the radiation planning is to deliver the uniform dose distribution throughout the target volume, which is called, we are talking about PTV, and ensure adequate tumor coverage. So we have to ensure, according to the protocols, different protocols established for the radiation oncology, we have to ensure the adequate tumor coverage and minimum doses to risk organs and normal tissues. For the breast cases, the risk organ usually lung and heart, and because it is very nearby and associated, and the opposite breast, which is contralateral breast. So let us know about the process map for the radiotherapy treatment. So I divide it into 7 steps. So usually there are so many things people are talking about, and they are making it maybe sometimes 5 steps or 10 steps. But if we see in the first step, that is called patient preparation and immobilization, we can say that is part of the mold work or immobilization work or patient preparation includes patient consent, we need to inform the patient, we need to train the patient what will be the instruction he need to follow during the course of the treatment. So some of the information we need to carry it out towards the patient. Then the number second is we need to do the simulation, which is called CT simulation. After that, that CT data will be transferring to the treatment planning system for the contouring and other things. So number three will be the contouring, target volume and risk organ. After finishing this contouring part, then the treatment planning starts, and the radiation medical physicist will start the treatment planning after completing the contouring part. Then when the continuing treatment planning being done, then the plan evaluation and approval work is conducted. And after the plan evaluation and approval, the plan is ready for the delivery. So before that, we have to do the, if it is IMRT or VMAT, then we have to do the plan QA before deliver the treatment. And if it is not IMRT, then we can just do the plan preparation work like our mosaic work. If it is Electra, then it is called mosaic work, and if it is Varian, then it is called ARIA work. After that, we have to work for the first day setup verification. So first day setup verification, so everybody will be there, like medical physicist, then radiation oncologist and technologist, all will be there during the first day of treatment. After that verifying, then the delivery used to happen. So this is how a radiation treatment process is actually happening in all the institution. So what we are doing in the patient preparation and immobilization, what is our role and what we need to do, we need to know. Most important aspect of positioning is patient comfort and reproducibility. We should not make any positioning which is actually not practically reproducible, or which will be potentially difficult to reproduce. So the most important aspect for the patient positioning before doing the CT scan, the mold work will be such like patient comfort will be there. The primary goal, reproducibility of the patient and reduce the positioning errors. And what are the other advantages of this? So can reduce time. If we do the immobilization thing, then it can reduce your time to daily setup. And patient feel comfort and secure and less apprehensive. And it helps to stabilize the relationship between external skin markers and internal structures. So this is this is the two types of patient positioning. One is supine and another is prone. So the left side image, when the supine position patient CT simulation being done, then the image looks like this. And when the prone position being done, then the image CT image looks like this. So there are some advantages, disadvantages of the supine and prone positioning of the breast irradiation. So there are lots of pros and cons. So what are the advantages? So it is very easy to set up. And secondly, tried and tested technique that staff are familiar with. And third one is it can match nodal fields, the supraclav nodal fields, to chest wall field when required. And the four is higher patient satisfaction, because obviously it is a patient comfort position. And what is the advantage of prone? So prone is narrowing of breast shape, makes gaining a homogeneous dose easier. And the secondly is respiration while prone is limited, reducing intrafractional movement. And the third one is organ at risk may be separated from the breast tissue, leading to reduction of lung volume. actually, which the lung and heart, especially the lung, sometimes very, very critical to spare. But there are some disadvantages as well for the supine and disadvantage is gravity effect on women with large breast can mean there is a loss of skin sparing inferiorly. When it is in when it will be in superior, maybe there will be some loss of skin sparing because gravity effect is there, and the immobilization of the breast tissue may be difficult in women with large or pendulous breast with unknown effect of subsequent cosmetics. But in the prawn, what is the disadvantages? The PTV often does not include the chest wall, which may be a problem depending on the position of the original tumor. And the number two is not possible to match on nodal fields. So number three is difficult for patient to climb onto the platform. Some ribs fracture reported because this position is not comfort, and if it is the patient is very bulky and a patient is not cooperative, so there may be a chance, a high chance to some accident or emergency happen. So that's what some ribs fracture reported. And number four, accuracy is not good as supine position. So these all the information I gathered from um, a reference, a systemic reference of a systemic review of methods to immobilize breast tissue during adjuvant breast radiation. There was a university, Sheffield Hallam University Research Archive, 2014. They have conducted a research on it, and they finally concluded these are the advantages and disadvantages. So this is, now we are talking about the positioning device. What are the positioning devices we used to use for the breast simulation, and what are the advantages? So we used to use actually breast board commonly, and in our setup we are using, there's a AIO breast board from Orfit. So this is having a cushion set and designed to achieve a comfortable and reproducible supine position of the patient. And this is tested, and this is clinically, all the information and data is viable towards the clinical efficacy. So number two is 90-degree, 10-degree, and 15-degree angle of and 20-degree, 30-degree angle of increase patient comfort, and armrest is allow for a comfortable but reproducible positioning of the arm above the head and out of the treatment field. So number three, there is a hand grip actually, and head support further help in increasing the precision and in finding the correct patient position. For the large pendulum breast, for the patient with large or pendulous breast, treated supine require a breast support either with a thermoplastic shell or cup, which can be used to bring the lateral and inferior part of the breast anteriorly away from the heart. Contouring work will be um, uh, done. So this is very important for the content person, even planning. So number three, radio wires also placed encircling breast tissue. And number four, CT data are acquired superiorly from neck and inferiorly up to diaphragm. So number five, we have to think about the slice thickness, which is sufficient for 5 mm, but if it is IMRT or VMAT and other high modality, high precision radiation, then it should be 2.5 mm is recommended. And number six is three reference tattoos are placed on the central slice or right and left sides so that measurement can be made to subsequent beam centers. Most patients are treated in the supine position with the arms abducted and face turned to the contralateral breast side. This is actually this is how patient need to position their body, because if it is the supraclavicle irradiation will be there or required, then this position need to. But if it is not only the chest wall, then the bending of the face is not mandatory, or it is not required. The arm position during the simulation, arm position, bilateral arm to be abducted 90 degree. This will be like this in the image. See, and this will be the arm position, and the advantage of this raising arm, like patient is more comfortable and relaxed. They'll be very relaxed and comfortable. And then number two is the position is more symmetrical and easily reproducible during with lesser chance of the rotation of the torso. That means body torso will be, the rotation will be less, very less chance. So more precise matching of the previously irradiated field if the contralateral breast requires radiation in future. So this the factors deciding the angle of the arm elevation, ability to elevate without discomfort. So this we need to consider. No need. If minimal skin fold of the supraclavicle, no or minimal skin fold, ability to move the patient through the CT aperture. So patient has to, it need to be keep in mind that according to this position, there will be no hit of the hand. If the patient is really very bulky, then maybe there will be a hit may happen. So we need to take care of these factors. So now there is another thing, the position of the head. We have to be very careful about the position of the head because rigid head holder or neck rest also required. See here in the picture, only headrest is not also. It need to be headrest with lateral neck flaps. So the neck will be fixed with that flaps. So there will be no chance to unstabilize the head position. And the number two is also elevate the chin. So it will elevate your chin, the patient chin, to minimize neck skin fold. So it will this position will make the patient anatomy like that the skin fold will be minimized after putting the head position on this headrest. So this is a very advantageous thing for the patient head. After that, after completing our simulation, we very careful which CT series we are going to transfer after this simulation. So we have to transfer the same data series which we are really which is really important. After that, the contouring target volumes, all the risk organs will be irradiated, will be contoured. So here you can see the heart, left lung, right lung, the PTV, CTV breast, PTV boost also here. So contralateral. These are the contouring part for the breast cancer patient. So what will be the target volume? It depends on the patient to patient. So maybe after breast conservative surgery, the one patient only whole breast radiation therapy. After that, it will be a lumpectomy boost. Maybe one patient is after the breast conservative surgery, only regional nodes need to be irradiated. That will be only the target. Maybe accelerated partial breast irradiation, very early breast cancer. So after mastectomy, this will be chest wall, mastectomy scar, or regional nodes. They are the targets for the breast cancer. So the dose prescription for the radiation planning. So there are three types of things we need to consider: the whole breast or chest wall. Then the dose will be like conventional. If it is, then 50 gray, 25 fraction. If it is hypofractionated, then 40 gray, 50 fraction, or 42.5 gray, 60 fraction, 16 fraction. So if it is boost, then 16 gray in 8 day fraction, or if it is lymph node irradiation, then 50, 25, or 40, 15. So these are the dose prescription are actually most common dose prescription for the breast cancer radiation planning. So let us go to the treatment planning techniques. And before that, I would like to show you this picture. In this picture, actually, what it says. Basically, in the left side, this cartoon man, actually, this is our goal. Which we want to make a shape from a wood from we want to make this kind of shape. But finally, how this treatment planning techniques are, the revolution is happening years to ago. Like in the era of 2D in 90s, the radiation, the goal we was not able to achieve. It looks like this. In the 3D CRT era, it was look like that. You can see the picture, and after that, now in the era of IMRT, it looks like actually it is near about the goal. So this is how the planning techniques actually different. The difference is like this way. So there are so many techniques, like one is 2D based planning, one 3D dimensional conformal radiation planning, and intensity modulated radiation planning, and volumetric modulated arc therapy, stereotactic body radiation therapy, and proton therapy. These are the techniques are happening in all over the world according to the patient and patient staging and condition. So now we want to talk about 2D planning, 2D based planning, how it was done, or it is still some of the places still this kind of planning is happening. So this 2D based planning, breastbone supine with anterior chest wall parallel to the couch, like that way they positioned, arm overhead and comfortable. If the two field, the patient looks straight. If three field technique, turn on the head to the opposite side to be treated. And the technique for the whole breast art is two tangential field are used. The additional field for supraclav, IMC, and post axillary may be used. So this is the four tangential field borders. So you can see, you can easily understand maybe upper border supraclavicular field used second intercostal space. So clavicular. So we have to, during the simulation, we have to do up to second intercostal space. When it is supraclavicular is not irradiated, then head of clavicle is okay. The medial border will be 1 centimeter away from the midline. You can see in the picture, and lateral border 2 to 3 centimeter beyond all the palpable breast tissue, no mid axillary line, and the lower border will be 2 centimeter below in primary fold. So you can see what is the definition of the in primary fold. So this is the fold. So the red circle I highlighted. So from there 2 centimeters. So this we have to think about this lower border. 2 centimeter from the inframemory fold. So note, border can be modified in order to cover entire breast tissue to include nodal volumes and scar marks. So deciding angle of the rotation of gantry for tangential field. So what are the techniques applied for this? Lead wire placed on lateral border, field opened at 0 degree rotation on chest wall, and central axis placed along medial border of the marked field, and gantry rotated until on fluoroscopy the central axis and lead wire intersect. When the lead wire intersect with the central axis, then that angle will be the medial tangent angle. After that, just 180 shift. Though this will be the medial and lateral tangent, and after that simulation film taken. So there are some new modifying devices in breast radiation therapy are using to because of the dose distribution complicated, is very difficult. So to make it irregular, though some bolus and wedges are used for this. So alignment of the tangential beam with the chest wall. How we can align the tangential beam with the chest wall? There are three ways actually has been practiced. Like one is rotating collimators, one is using breastboard, and another is multi-leaf collimation. So in the first one, the rotating collimator is like sloping surface of the chest wall. As it is a sloping surface, if you see there is a difference between these two pictures, there is no collimation. So this looks like the this, and in the above picture there is no collimation, but you can see the square box. It is easy, you can easily understand about the lung area, how lung area amount of lung is more compare. If we are making the collimator rotation, then the amount of lung volume is actually reduced. So this is a one way to reduce the lung volume. And the second one is, if we see board, though we are doing this collimation, but this collimator change also having some uh, potential issues and problematic things when there will be a supraclav field become, because we need to match the junction. So between bitangential field, when we need to match the bitangential field with the supraclavian field, so it becomes like hot and cold spot. You can see in the picture, and this is how there is a uncertainty happening. So this kind of issue we can resolve by the breastboard, and what we are practicing for the now 3D CRT, we used to use this breastboard, and these wedges is very helpful to reduce the lung volume, as well as to make the chest wall horizontal according to the patient contour, and it is very effective. So, and the number three is multi-leaf collimator. So multi-leaf collimator, so though it is multi-leaf collimator for the 2D era, it has some limitation because of their multi-leaf collimator thickness itself having some limitation. So this was actually practiced for the 2D planning, so where the 3D planning is not available. And the energy is like 4 to 6 MV. Still it is the gold standard, this energy. And photon energy, when the 6 MB is not when the 6 MB, because when the underdose superficial tissue, the skin surface is required, then we need to increase the dose. If the tangential field separation is very high, that means more than 22, then the higher energy photon will be used to deliver this radiation. So, and the boost to the tumor site, how we did the boost. Local recurrence tend to be the primarily and the primary tumor site. So in that time, and the boost will be the low risks of marginal recurrence. So most advantages when the margin is unknown and young women less than 40 years. So this is how the boost concept is the electron boost is having practiced. And boost electron is the position, the electron therapy is positioning like this picture. So this is how the electron therapy is giving. The accelerator head point is straight down on the target volume, and the energy is selected like it, the 90% isodose should cover the tumor bed. So this there is a calculation we need to do, manual calculation. So we can do manual as well as nowadays it is possible by the treatment planning system also. So the approximate energy was like there is a thumb rule 4 into x. Likewise, the energy was selected. There are some disadvantages as we know. The beam matching can be very difficult, and dosimetry performed only on the mid plane of the target. Dose distribution can be inhomogeneous away from the central axis, and those to the where heart and lung cannot be determined accurately. Shielding of heart while treating the left breast would not sure whether a part of target volume being missed. So in the era of 2D, there is a hard blocking actually happen. So during this hard blocking, so there is a chance to miss the target volume. So now we want to talk about this three-dimensional conformal radiation therapy. Why three-dimensional? What is the advantages?
Sorry for
So
interrupting.
this is yes.
Now I'd like to request complete your speech within 5 minutes.
Uh, So in the three-dimensional conformal radiation therapy, you can see this is the we incorporate with treatment planning system, and it has become easier to generate multiple beams. And the most serious concern for the breast radiotherapy is cardiac toxicity, and that era, so that the risks of this cardiac complication increased actually linearly when the mean heart dose is 1 gram mean heart dose increment is increased the 7.5% of the cardiac toxicity. So it is the reference, this reference is stated this information. So there and compared to 2D, this conformal radiation therapy combination of the gantry angle, field in field, and beam weightage, beam pair, multi-leaf collimation, different energy combination, are different effective way to reduce heart dose with 3D CRT. So why 3D CRT? Also, it is to avoid inadequate target coverage due to respiratory motion in the 2D era. Anterior border field 1.5 to 2 centimeters. So to accommodate the breast during respiration, and in the 2D, the mechanical block for the heart and lung was there, but now it is by MLC, so it is very easy to block that. And that heart and lung. So 3D plan found to be dosimetrically superior compared to the standard 2D plan. So this is how it moves to the 3D CRT. And there is another thing is that particular concern for the secondary malignancy, multi-field conformal radiotherapy has the risk of a greater volume of the normal tissue receiving low dose of radiation, which is the secondary malignancy. So this can be reduced, this can be controlled by the 3D CRT. So this is a typical 3D CRT plan for the isodose display after that CT simulation and thing. And this is how all the geometric things happened. And now intensity modulation is this is the high precision radiation therapy, and that uses computer controlled linear accelerator to deliver precise radiation doses. to the malignant tumor or a specific area within tumor. So this IMRT allows three-dimensional shapes of the tumor by modulating or controlling the intensity of the beam by multiple small volumes. So IMRT is allows higher radiation dose to the focused tumor in normal critical structures. So why IMRT? So IMRT is promising because of the excellent dose distribution and organ sparing, and it is actually available direct beam along with the facility to either treat and the fixed beam technique. IMRT is a game changer for the modern radiation practice. Dosimetric study have successfully documented that the tangent IMRT is superior, and but one thing we need to understand, keep in mind that in the cost of increased low dose normal tissue volume. So we have to analyze this portion also. So selection of the beam energy number and direction of the IMRT. So uh, this is how in the clinical situation without significant target concavities, the beams what we are using in 3D CRT, it can be sufficient for the IMU also. If it is not that much concave target, and we can use 5 to 9 uniformity spaced beam, and if it is non-planar beam is required, then we can use also. And the third one is attention should be paid to unconstrained normal tissue in the path of the beam. So in the path of the beam, when we are placing a number of beams in the IMRT, so we have to consider what are the normal tissue in the path of the beam. So if that will be unnoticed, then that may unacceptably high dose that can get. So we have to, during the optimization, we have to focus, we have to careful review on the dose distribution of those areas, and we can control by IMRT as well, which is not possible by 3D CRT. So this is the dosimetric advantages of IMRT. You can see there is two pictures. So better dose homogeneity for the whole breast RT, and that reduce hot spot. The superior and inframarginal portion of the breast. You can see the right side image, that central axis. In the standard wedges, the hot spot is very high here, but in the IMRT, you can control this hot spot as well as the infrared fold. In the 3D CRT, it is very high. Hot area is used to created, but you can control in the IMRT by this. And when we see then the IMRT, the coverage, you can see the coverage of IMRT and 3D CRT of the 95%. And this there is another advantage is like it can be used for IMRTs for SIV technique. We can do, for example, if it is 60 gray dose, 50 gray to the chest wall, and boost for the boost dose to the tumor for 10 gray. Though, so in the same fraction, we can make a plan for the SIV by IMRT, and it can decrease the critical organs and left-sided tumors. It can decrease the hard dose compared to 3D CRT. So this is the dosimetric disadvantages of IMRT compared to 3D CRT. You can see the 5 grade dose, so it is very spread out in the IMRT, but whereas in the 3D CRT it is not that. So it may increase the volume of the tissue exposed to the lower dose, and increase of the secondary malignancy. There is a chance it will increase. So what is the challenge for doing IMRT breast treatment? So caution must be exercised before implementing this technique to avoid unnecessary and unprecedented high dose to normal tissue in order to achieve target coverage. Entire idea of IMRT can be backfire due to its double-edged sword nature, and rigorous quality assurance training expertise in different aspects of radiation planning, starting from the immobilization to treatment verification and toxicity evaluation, are crucial. So these are the challenges for the IMRT breast treatment. And the challenges for doing IMRT breast treatment. So one less discussed issue about IMRT in breast cancer is lung dose, which is resulting toxicity. And this clinical data says these advent new techniques, one every year, the replacement, the older one, is definitely not a good sign, because this late pulmonary effect of the breast radiation of the lung, so it need require many years for the particular technique of a systemic follow-up. This is a challenge actually. So there is no such type of data or such type of follow-up to look into the late pulmonary effects of the lung. So this is this is the volumetric arc therapy. So continuously it can modulate, and with the multi-leaf collimator, and dose rate as well, entry speed as well. So this radiation delivered to the intended area only, allowing the radiation oncologist to spare more surrounding healthy tissue compared to IMRT. So we can spare the more normal tissues. So this picture can understand that VMAT and IMRT are equally effective for normal tissue sparing. However, the treatment time VMAT is significantly shorter, and that is the main benefit, that if any patient required a long time treatment, treatment time is very long, so the geometrical miss or the systemic error is very high. So we can control that systemic error or geometrical error by giving this radiation to a short time. So this is how VMAT is helping us to give radiation those patients who need more treatment time in the IMRT. So in the VMAT, this treatment time is really short. In the challenges of VMAT breast treatment, so there are some recent articles I have collected, that there are some hybrid volumetric arc therapy, which they are incorporated with 3D CRT, and that trial is still happening. This type of articles, they showed good outcome compared to others techniques. So these are the challenges when we are doing any techniques, still it is not that established. So that time there are some trial is happening and some other things is coming up with so there are a lot of radiobiology need to be evaluated for this type of things. So these are the challenges what I feel for the VMAT when we are doing any VMAT, because some people are thinking about hybrid VMAT, so hyperfractionated BMAT. So we need to know about the radiobiology for this type of techniques. So there are challenges for the VMAT technique. There are some people, there are some researchers understand they did some research on the VMAT, that is called, they subdivided these targets into three parts, and according that three part they use six arcs. We are using two arcs, but they're using six arcs, and that called segmented treatments, target segmented planning by VMAT. So these are the challenges, because this type of planning required systemic consistency. So if the systemic consistency is not there, so this type of technique is actually not. It is very challenging to deliver in the real patient. Another challenge is like, see here, there is another research that deep inspiration breath hold technique. So even IMRT 3D CRT with deep DIBH is better technique to sparing heart tissue. Even it is comparable with VMAT even. So this is very this is how the technology is going forward. So stereotactic, as we know, in the modern breast radiation, it is also in the field. So high dose per fraction, and it is a single fraction or multiple fraction, and there are patient selection will be there. The tumor will be need to be intact, surgically small target volume and post-operative target, or tumor having intact blood supply. So short target volume the data of SBOT still for the breast cancer is not mature enough and not validated in a large prospective study with long-term follow-up in terms of long-term disease control, control.
Sorry for interrupt again.
Challenges for doing is
Already you have said.
just 2 minutes.
Okay,
2 minutes. Challenges for doing SBOT breast treatment. So for the breast treatment, actually, the real-time tumor tracking is a must. So without that, without this, SBOT should not perform. So this is the reference, and this reference says the tumor tracking system we have to establish. So this is the proton therapy for the breast cancer. So in that backpick advantages and OAR sparing in a great extent by proton therapy. So depending on the depth and thickness of the PTV, so best conformity to the tumor, skin sparing and adequate coverage of the tumor cavity, and it is nowadays it is become the early breast cancer and post mastectomy radiotherapy. It is implemented. So majority of the dosimetry work is evaluating the role of this APBI and chest wall radiotherapy. Cardiac sparing and skin sparing excellent in this initial reports. So this is the actually this is how the proton therapy is giving. This is how we can reduce the heart dose. And this is my last slide. Because of the breast cancer awareness month, I want to share with this information to all of you that American Cancer Society guideline for the early detection of cancer. So when the age is 40 to 44, then the recommendation is annual breast cancer screening with mammogram if they wish to do. If the age is 45 to 50, then should get mammogram every year, and if it is 55 and older, then switch to mammogram every 2 years and can continue yearly screening. This is how early detection of cancer for the breast can be done. So let's defeat breast cancer together. Thank you for your valuable time. Thank you.
thank you, Mr. Masud Rana, for sharing your profound knowledge with us.
Thank you.
Now, we take some questions. The first question is Mr. Shravan Kumar, why you want to mark field borders in simulation for 3D CRT, IMRT, BMAT, etc.?
Why? Yes, sorry?
Why you want to mark field border in simulation for 3D CRT, IMRT, and BMAT?
See, if we mark actually during the contouring time, it will help to contouring the OARs and target volumes, and it is happening. It is a guideline.
Okay. Another question from Mr. Mustafizur Rahman. Sometimes it has been chosen to give wire by a copper wire or lead wire to the breast only and to the field area. Scars mark as well. So which is the best wiring to give this?
Scar mark is the what? Which mark actually? Lead mark, right?
Yes. Lead wire to
No, actually, lead wire. Actually, lead wire is the standard to mark this kind of marking because it is more visible in the imaging, and it is less image distortion. It has less image distortion. That's what people are using more in the lead wire.
Okay. Another questions. How will you keep arm position if you want to treat SCF and axillary?
Can you please tell me again how?
How will you keep arm position if you want to treat SCF and axillary?
Uh, if it is supraclavicular, then as I show you in the very beginning, that arm position will be there is a setup for the CT simulation. So we have to position the arm with a handle. So with that, it will be 90-degree angulation, and a patient relax need to be taken care. If the patient having some difficulties for raising his her hand, so we have to take care first that one. Then if we can if she is comfortable, then we that hand will be like as I show you in the picture. um, it will be like, yes, it will be like this. So it will be like this in a relaxed position. So we need to take care. And when in the axillary supraclavicular, if we are not making the position like this, then the supraclavicular fold will be irradiated more, and there is a chance for the skin reaction. So that need to be taken care. Yes. Hello.
Hello, are you hearing?
Yes,
Okay.
I'm hearing. Yes.
Another question. What is the main difference for breast treatment with DIBS techniques and without DIBS techniques?
Actually, there are so many articles and research still happening, but DIBHS nowadays, when we are we want to do the DIBHS, then we have to get all the technical support to conduct this DIBHS BAs. Not only that, patient need to cooperate. If the patient is not that cooperate, and patient we have to train the patient, and she has to perform accordingly. If the patient is not able to perform, then this this technique actually will not work practically. So the patient selection for the DIBH is very important, what I feel. And my experience, I feel the patient selection is more important. If the patient is not fit or feasible for DIBH, then the technical, though we have all the technical stuffs, but it will not be helpful in clinically.
Okay, thank you. Another question. Is IMRT standard for breast cancer?
As I told in the presentation, that is still maybe after 3D CRT, when the IMRT came to the radiation field, that time IMRT was a very lucrative technique for this radiation oncology field. But after having that plan evaluation, maybe the trials and that research, and that low dose spreading was really more, as well as the when we are doing any IMRT, then the treatment time is more than sometimes more than 20 minutes. So the geometrical patient patient respiration, these all need to be taken care. If it is not taken care, then IMRT is not actually sometimes 3D CRT with DIBHS is more feasible, and sometimes 3D CRT is more feasible than IMRT. So there are so many pros and cons for this statement. So we cannot say IMRT is better for breast treatment. Even we can say VMAT. Sometimes some people showed in the research that VMAT sometimes is not VMAT sometimes is not superior than 3D CRT even.
Okay. Another question from physicist Pramod Jadhav. How much dose
Yes.
limit practice in your hospital for contractile breast and oncologist contour contractile breast?
For the contralateral breast, we used to see the mean dose and 1% dose, 1% volume is how much is getting. So we used to take care 1% volume will not more than 5 gray, and the mean dose should be less than 5 gray. Yes.
Okay, thank you. Another question from Shravan Kumar. Forward IMRT versus inverse IMRT, which one is the better for breast?
Actually, forward IMRT is a kind of 3D CRT, but that 3D CRT having segment, so that is called forward IMRT. And when it is IMRT, then the if the lung distance is which is called CLD, central lung distance is more than 2.5, then I think 3D CRT forward IMRT is good enough to take care the lung dose. If this CLD is less than 2.5, even 2, then actually lung dose taken care by forward IMRT is also not possible. So if we really want to control the lung dose, that is ipsilateral lung dose, then we have to in that content we can say IMRT is better, but yeah, otherwise I do prefer forward IMRT.
Okay, thank you. Another questions from Dinesh Soros. Can you highlight the role of hybrid IMRT and VMAT treatment in CA breast?
Actually, still we did not practice this one, and I need to uh, this hybrid IMRT, which is recently published last 2 months, hybrid VMAT last 2 months back. So I think we can make a trial and see how actually what is happening.
Okay.
Yes.
Another questions. Do you think SORT is better for breast irradiation and same SGRT is better for breast irradiation?
SBRT.
SGRT and SORT.
Oh, SGRT. Yes, SGRT actually it depends when sometimes when there will be a yes. So if they are contour of the body having a chance to change dramatically, then SGRT is really helpful as well as. So and we can use this SGRT for breast treatment, and I hope this SGRT will be helpful if we incorporate with the delivery technique, because if this delivery technique will be radiation delivery will be incorporated and it can control the radiation delivery, then it will be very effective, and practically it will benefit to the patient. And what we really want to control the lung dose as well as that breast to control or to monitor the respiration, that will be really practically possible. But I am very hopeful about HTRT. Yes. Hello.
So sorry. Another questions. I want to ask about prone breast irradiation benefits and risks.
As I showed, actually, prawn position is very limited use, and it is not appreciated. If it is really needed, if it is really needed, then only people sometimes using this prawn position. But mostly, most people are using supine position, so it is not a appreciated technique actually.
Okay.
Yes.
Thank you. Another questions. Could you give your point of view on the use of proton therapy in breast cancer?
Actually, I don't have a clinical experience about proton therapy, but what I feel, it is very much selective and dependent on the patient selection. This is my understanding. So it is not that to just get the advantages of cardiac sparing, we should go for the proton therapy. If the patient having the chances of cure is very high, and the radiation oncologist and the surgeon are really taking care their clinical outcomes, and then people should go for the proton beam. This is my understanding. But if it is not really needed, then this is not needed. This is my understanding and opinion.
Okay. We'll take one more questions.
Yes.
And the last question is from Ram Narayan Jadhav. What is the conditions to prescribe 50, 40, and 42.56 grays separately? What are the benefits for hybrid treatment planning in breast?
Uh, Actually, the dose prescription is depend on the patient condition and pathology and the staging. So sometimes we are seeing some patient having that whole breast, and they are getting 50 gray. Sometimes we are seeing hyperfraction the regimen they want to try, or they want to agree for the curative intent. Then it is 40 gray, and when the 40 gray hyperfraction is the condition, then we used to analyze, and we used to account the radiobiological effective dose, not the conventional way. We are converting the dose to the BED, according to BED. And this hybrid technique, still we are not practicing that hybrid planning, because this 3D CRT combination with VMAT we didn't try so far.
Okay. This is the last
Yes.
questions. What is the dose constants you accept for the heart with IMC and TTT?
I think it is, I think IMRT, you want to say IMRT? So, treatment. So in the IMRT or VMAT, when we are doing any IMRT and VMAT, so our mean dose of the heart, we usually get 6 to 7 mean gray. But if it is 3D CRT, the dose we used to get for the heart 8 to 9 gray for the 3D CRT, and when it is VMAT on IMRT, then we easily achieve it below 6 6, sometimes it can be 5. It depends on the lung distance, how far it is. Yes.
Okay. Thank you.
Thank you. Thank you. Thank you so much.
Thank you very much.
Thank you all.
Sorry.
Thank you all for your valuable time to hearing me actually. Thank you.
Thank you. I'd look to thanks our speaker and also participants. Last but not least, I thank you all the participants for showing their interest in the program. I once again thanks our honorable speaker and participants for making this program successful. Thank you.